analgesics, about the judicious use, because analgesics are double-edged swords, and as we'll see during the course of the talk, that there are many side effects. They can be avoided if you use it correctly. That pain is always a personal experience influenced by psychological and social factors. It's very, very important that whenever we prescribe paracetamol, remember, could the patient have chronic liver disease, or is the patient is taking alcohol? Very, very important. And if you combine 400 milligram ibuprofen and paracetamol 1000 milligram, it is 1.5. That is why you'll see that many of the combinations of ibuprofen and paracetamol, very common name, I wouldn't name it, but very common brand name, which has got ibuprofen 400 milligram and paracetamol 500 milligram, and they are the best analgesic. So for inflammatory dose of ibuprofen may be high, but for analgesic dose, it's much lower.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Good evening and welcome all the viewers and especially seniors, Dr. Atul Parekh and many of our colleagues who are there right on dot. Today's topic is ABC of Analgesics. I have kept the topic a very broad one, but still we'll restrict to some of the basics things, not the entire E to Z of analgesics. That's not possible in a time that we are going to have. So the very objective of this talk is to emphasize, to find the cause and the type of pain before prescribing analgesic whenever it is possible. At least in the chronic setup, it is always possible to find out the cause, the type of cause, the type of pain that is the patient is suffering from. And second part is to sensitize all the stakeholders, that means the patients and the relatives who keep on demanding or who use OTC products for the analgesics, about the judicious use, because analgesics are double-edged swords, and as we'll see during the course of the talk, that there are many side effects. They can be avoided if you use it correctly. So what I'm going to talk about is the first few minutes I'll be talking about the pain, the type of pain, pain receptors, and then we'll go to the classification of analgesics, mechanism of action of different types of analgesics, what are the uses of these different kinds of analgesics, which particular indication we would be using one particular analgesic, and what are the adverse effects. What we will not be able to discuss for want of time is there are many drugs which technically can be called analgesics because they relieve pain. Suppose the patient has angina, then nitrites would relieve the pain, but that we are not going to use and discuss here. Likewise, patients who have got acid peptic disease, they will have pain in the epigastrium, right, or intestinal region, and proton pump inhibitors and antacids would also take care of their pain, but that will not be discussing here. Like patient who has got severe headache because of the raised intraocular pressure, uh, then obviously the intraocular pressure reducing drugs are required. Such kind of treatment we are not going to discuss here, even though they are the analgesics technically. Likewise, there are many specific pain syndromes where the type of drugs are other than the routine analgesics or over and above the analgesics, like migraine, trigeminal neuralgia. These are the conditions where you use many other drugs also that we'll not be discussing. Then there are many situations where we use muscle relaxants, and antispasmodic drugs for relieving the pain. That also would be not the scope of this because of the time, but we may discuss them during the question and answer sessions. Then non-pharmacological modalities are used, especially in chronic setup, like acupuncture, yoga, hypnotherapy, cognitive uh, behavior therapy, botulinum tox, etc. That also we would not be discussing. The reason is only the time, because as I said earlier also that we are not discussing A to Z of analgesics, but we are discussing the ABC of analgesics or basics of analgesics. The reason is only the time. Now, before we discuss the topic of analgesics, we need to know that what is pain, because unless we know the pain, we characterize the pain and we pinpoint the cause of pain, probably we will not be able to use the right analgesic. So first I'll be describing the definitions, the type and cause of pain. So what is pain? Its definition appears very complicated, and this is what the definition for most of the situations are. That this definition is given by the International Association for the Study of Pain Council. They have revised it in 2020, and the definition of pain goes by it's an unpleasant sensory and emotional experience. Unpleasant sensory and emotional experience which is associated with or resembling associated with actual or potential tissue damage. So there is a sensation, emotional experience, and either there is an actual or potential tissue damage. So that is what the old definition of pain is. It's an unpleasant sensory or emotional experience associated with or resembling that associated with actual or potential tissue damage. So what we mean by is that pain is always a personal experience influenced by psychological and social factors. Severity of pain may or may not be correlated to the severity of disease. We know that if I complain of headache and if a manual laborer complain of headache, the outcomes are different. We are not that tolerant about any of the inconveniences. So our headache may appear very severe and the cause may not be that severe. But a person who is generally very strong, stout, or very hardworking persons, or whose tolerance is very good, and if he complains of pain anywhere, I think we should take that pain very seriously. So severity of the pain differs from person to person, and the complaint also may not be related to the actual severity of the disease. Tissue damage may or may not be present or may not be perceived by the patient. That is very, very important. That will dwell further. What are the common causes of pain where we have to prescribe analgesics? Most acute conditions are very obvious, like patient who has got post-operative pain, patient who has a post-traumatic pain, musculoskeletal strains and sprains, or inflammatory conditions, acute chikungunya or any viral infections or dengue where they have got headache, all this pain. So, which are very, very obvious. Here, the treatment is that of the analgesics as well as the primary conditions. If the patient has a fracture, immobilizing the fracture is very, very important, and that is the first thing that we have to do it. Likewise, if there is an abscess causing the pain, we have to drain the abscess. So analgesics plus the uh, whatever is the underlying cause need to be treated. That is for the acute pain. Acute pain, as we said, post-operative, post-traumatic, musculoskeletal, and inflammatory conditions. These are just the representative common causes. They are not the total causes or all the causes we are talking about. Likewise, for chronic pain, we got many conditions where patients keep on coming or changing one to the other doctors for want of relief of their symptoms, like fibromyalgia, tension headache, connective tissue disease or arthritis, sciatica, chronic inflammatory conditions, irritable bowel syndrome. So these are the conditions where the patients will have pain for days together or years together. What kind of pain we are talking about? Patient may have nociceptive pain, patient may have neuropathic pain, or patient may have neuroplastic pain. These are the representative conditions I have shown in the pictures, and that will be talking further. So mainly there are three types of pain: nociceptive pain, neuropathic pain, and neuroplastic pain, which is a combination of nociception and neuropathic pain, though it's also called nociplastic pain. How do we define them or differentiate them? See, nociceptive pain is one which is the commonest what we see in the acute settings. Whenever the patient has damage to the body tissues, whether it's an injury or fracture or arthritis or pulled muscles or direct injury like renal colic or appendicitis, these are all because of the stimulation of the nociceptive receptors. And there is always a stimulus present. These patients' pains are usually acute and they respond very well to analgesics. So that is nociceptive pain will further evolve how they develop. Second is neuropathic pain. Here the damage to the nervous system is from the disease of the or injury to the nervous structures, nerves, or neurovascular bundles. Whether patient may have single, sciatica, diabetic neuropathy, trigeminal neuralgia, or as I said, phantom limb, something where the stimulus may or may not be present, or there may not be any damage to the nerves, right? So stimulus may or may not be present in neuropathic pain. Neuropathic pains are usually long lasting and they do not respond as well to nociceptive pain. Neuropathic pain is this. Neuroplastic pain are here the pain is because of the altered nociceptions. So there is no clear-cut actual or threatened tissue damage in many of the cases. If we take the examples of fibromyalgia or irritable bowel syndrome, they complain of very vague pain. For fibromyalgia, they have pain all the time in the pain around the joints, and they have unrefreshing sleep, and they have got tender points. But there, when we examine or we investigate, we do not find any damage to the structures. Likewise, irritable bowel syndrome patients would have pain, but all the investigation would be normal. So these are the pains for which the explanation is neuroplastic pain, or it is an altered nociceptions. The body, the nervous system has a very remarkable capacity of neuroplasticity. What we mean neuroplasticity is they can alter the pain response. Here only the problem is that the response is in the form of pain, but otherwise neuroplasticity is now used very much for the relieving of the many chronic pains to change the response of the body to the any structures. So what is nociceptive pain? Nociceptive pain is caused by the noxious stimuli. Noxious stimuli are the one which are perceived by the nociceptors. So whether it's a skin, joint, muscles, viscera, these are all, there are specialized sensory receptors which are present in the peripheral nervous system. These are called nociceptors. As we know that these nerve endings, free nerve endings which are present at the dermis and epidermis layers, they pick up these signals, then they travel along the sensory nerves, and through the dorsal ganglia, they go to the spinothalamic trend, to the thalamus, and to the highest posterior cerebral cortex. So this is posterior sensory part of the cerebral cortex. So this is the pain. This is how the pain is traversed. So these are the skin receptors, and the receptors can again be different types. They can be chemical receptors, mechanical receptors, thermal receptors, silent receptors. The chemicals can be again various types of chemicals are known to produce or initiate the pain, and that is protein kinase, arachidonic acid, histamine, and one of them very important is calcitonin gene related peptide. We recently had CGRP related all blockers or the antibodies which are very much coming up in the treatment of migraine, whether it's an acute attack or it's a prevention of migraine. CGRP related peptide blockers or antagonists are now used very much for the migraine. Likewise, serotonin, lactic acid, these are all the chemicals which also are known to initiate the nociceptive pain. So this is all about the type of pain. If we know the type of pain, we can select a particular drug. Nociceptive pains are easier to treat against the neuropathic pain or the neuroplastic pain that we have just seen. So what is analgesics? Analgesics it's a Greek word combination of prefix n and the suffix algos. It's a pain, and without pain that is analgesics. Earlier it used to be known as anodyne, but now we call it analgesics. We know pain is universal and it contributes to morbidity, mortality, disability, burden on healthcare system. I'm sure all of us have suffered from pain one or the other time and also have prescribed analgesics time and again. So what are the analgesics classifications? They are broadly classified into opioid analgesics and non-opioid analgesics. Opioid analgesics, we have got many compounds. To name a few: morphine, ethidine, tramadol, buprenorphine, and fentanyl. These are the used opioid analgesics, of which probably we most commonly use tramadol, sometimes use buprenorphine, and in select cases we also use fentanyl. Non-opioid analgesics are the one which we most often use in our OPD practice as well as in the acute setting also. There is an acetaminophen, also called paracetamol, non-steroidal anti-inflammatory drugs, anti-epileptic drugs, antidepressant drugs, and local anesthetics. These are all the drugs we use routinely day in, day out for our practice. Before 40 years, WHO came out with a pain management ladder for chronic cancer pains, and this still holds true for most of the selection of analgesics on a chronic settings. You always start with a mild analgesics for a patients who have got a mild pain, minimum pain without disability. Like we start with the step one treatment is always paracetamol or non-steroidal anti-inflammatory drugs. If the patient pain is severe, then we may add tramadol, codeine, or hydrocodone. We use usually tramadol here. And in step three, we go for a powerful analgesics. That is the place when probably we have to use a very strong opioid analgesics like morphine or fentanyl. So this is the chronic pain WHO ladder for pain management. We start with paracetamol. We are going to discuss 4 drugs most commonly because that is one we use the most. One is paracetamol. Second is a whole group of drugs called non-steroidal anti-inflammatory drugs. Third is the tramadol. And the fourth is the gabapentinoids or pregabalin and gabapentin. These are the 4 drugs we use most commonly for our day-to-day analgesic use. So paracetamol is obviously the commonest and the first prescription for most of the pains. Earlier, it was believed that paracetamol works on the cyclooxygenase enzymes in the central nervous system, where it decreases the prostaglandin synthesis. Cyclooxygenase enzymes also present in the periphery in the WBCs also, but paracetamol selectively inhibits the prostaglandin synthesis in the central nervous system, and that is why we do not have any anti-inflammatory effects, which is when the drugs works on the cyclooxygenase of the peripheral tissues and the neutrophils. But now the recent data suggests that the paracetamol has a multimodal analgesic effects. It not only works on the prostaglandin synthesis inhibitions, but it also works on the other receptors like endocannabinoid receptors, like the morphine-like receptors, or it also works on the serotonergic as well as the nitric oxide mechanism. So paracetamol has a multimodal actions, and that is why it is truly a good analgesic and a very safe one. How it works? Whenever the paracetamol is subjected to the deacetylation in the liver, it produces para-aminophenol, which when enters the blood-brain barrier, it is converted into a product called AM404. Why we need to know AM404? Because this is the one which is extracted from the brain or the CSF by one of the Indian scientists, and now it is accepted universally that this is the one which is responsible for the analgesic effect of paracetamol. AM404 is for the analgesic effect of paracetamol. It not only inhibits the prostaglandin synthesis, but it also works on the serotonergic as well as the nitric oxide pathways. Paracetamol recommended dose is 650 milligram to 1000 milligram 4 to 6 times a day. The maximum of 4 grams per day. All those that we are talking about is for adults, right? So up to 4 grams we can give it. In children, the dose is 15 milligram per kilogram, 6 hourly, and maximum dose remains 60 milligram per kilogram day. Paracetamol is one drug where we have to keep in mind the weight of the person, because the higher the dose, higher the chances of liver toxicity, especially. So whenever the patient has hepatic impairment or patient who is chronic alcoholic, we should not give more than 2 grams per day. It's very, very important that we stick to this, or we inquire about the either there is a chance of liver impairment or patient is taking alcohol before prescribing analgesics like paracetamol in a higher dose. It's available in many types of preparations, whether it's oral, tablet, capsule, syrup, as well as we also get suppository as well as injections like intravenous as well as intramuscular injections. But intramuscular injections are less preferred. The reason is it is having an erratic absorption and significant local reaction. So always use paracetamol intravenously when you want the immediate effect. Very important is always keep in mind the hepatotoxicity. It's a very, very well established and major cause of concern when we prescribe paracetamol in a higher dose or for a longer time. The reason is a toxic compound called NAPQI. NAPQI is the toxic metabolite of paracetamol. which is always produced in a small quantity when you give a small quantity of paracetamol, but that is immediately detoxified by glutathione. But when the patient is taking excess of paracetamol, either accidentally or if with a suicidal intent, or if the patient has chronic liver disease or patient is alcoholic, these glutathione stores are depleted or decreased, and it leads to very high levels of NABQI, and that leads to liver failure and necrosis. And it takes a very short time to go into acute liver necrosis, and many of the patients are subjected to liver transplantation for surviving their for the life. So it's very, very important that whenever we prescribe paracetamol, remember, could the patient have chronic liver disease, or is the patient is taking alcohol? Very, very important. So that's all about the paracetamol. Then second part is the NSAIDs. Before that, I thought that let us discuss something about NNT, what is called number needed to treat. This is a very important and simple marker or measure of effectiveness of any interventions. If we want to know whether the particular drug is effective compared to the other drugs of the same class or other class, we need to get the NNT or number needed to treat. If we talk of analgesics, for a single dose of analgesics, for any moderate to severe pain, if there is at least 50% pain relief over next 4 to 6 hours, right, then we consider that drug is effective. Now, what is NNT? NNT is the number of patients need to be treated in the intervention group for benefit compared to the control group where there is no benefits. You give one group of intervention group the drugs, say suppose we give paracetamol, another group we do not give paracetamol, and we see the effect and see whether there is how much is the effect of this particular drug. So if treatment works in the everyone in the intervention group and where no patient has a response in the control group, right, that means the number needed to treat is 1. Lower the number, better is the treatment. So whenever we see NNT for any drug, whether it's gabaline, pregabalin, or gabapentin, or ibugesic, or diclofenac, always look for NNT if it is possible. If the number needed to treat is less, as far as analgesics are concerned, if it is between 2 and 5, it's an effective analgesic drug. But there is also another thing that is called number needed to harm, that is NNH. That is how many patients need to be treated to get an experience of a side effect, adverse effect. So that is number needed to harm. Obviously, higher the number, that's better there, because that means you need 100 patients to get one side effect if it is 100. So always remember NNT and NNH. So why we need to discuss about it? Because this is the slide will explain that what is NNT for analgesic effect of all these drugs. If you see the drug and its NNT, say ketorolac has the best NNT, that means only 1.8. That means if you treat 18 patients, 10 patients will be benefited, like that. So because with the dose of 20 milligram of ketorolac, the NNT is 1.8. For diclofenac, it is 2.3. For ibuprofen, 400 milligram, it is 2.4. As against paracetamol, 1000 milligram is 3.8, right? And morphine has 2.9, not as good as ketorolac as far as the analgesics are concerned. Of course, this is one paper and one study, which was, of course, done in many number of patients, and it has been often quoted since 2007. Likewise, if you see codeine is a very high NNT. Right? So always try to look for this. Naproxen as good. Up to, I would say, aspirin, the NNT suggests that they are all good analgesics. But if we combine two drugs, right, that NNT would come down. So ibuprofen 200 milligram has 3. But if you combine ibuprofen and paracetamol, it comes to 1.6. And if you combine 400 milligram ibuprofen and paracetamol 1000 milligram, it is 1.5. That is why you will see that many of the combinations of ibuprofen and paracetamol, very common name, I wouldn't name it, but very common brand name, which has got ibuprofen 400 milligram and paracetamol 500 milligram, and they are the best analgesics. So for inflammatory dose of ibuprofen may be high, but for analgesic dose, it's much lower. Another important concept, this is probably one of the most important slides to me as far as the NSAIDs are concerned, that whenever we talk of NSAIDs, we must talk of cyclooxygenase 1 and cyclooxygenase 2 enzymes. These are the enzyme systems which are very important for maintenance of normal homeostasis, or what is called housekeeping. We know that arachidonic acid is the one where this, which is the important substrate from which we get our many of the hormones. We also get the platelets functioning properly, all our gastric mucosa or renal mucosa, and they are all protected by the cyclooxygenase 1 enzymes. Right? This is called arachidonic acid constitutive. Constitutive means they are routinely at quiet time also at all the time. This COX-1 enzymes converts arachidonic acid into the blood clotting as well as acid and mucous productions and renal protections because of the productions of prostaglandins, production of prostacyclin and thromboxane. So these are these substances which are produced by the COX-1 and they maintain the normal homeostasis. While COX-2 is produced mainly inducible, that means whenever there is an insult like inflammatory stimulus, whenever there is an injury or infection, that will increase COX-2. So constitutively also COX-2 does produce prostacyclin. This is very, very important property of COX-2, that constitutively COX-2 is producing prostacyclin, while COX-2 is mainly produced by the inflammations, and that produce large number of prostaglandins, and which will produce the signs of inflammation, which is pain, swelling, heat, or all these things, right? So now we come to the COX-1 and COX-2 inhibitions in different NSAIDs. We know that ibuprofen has 0.5, naproxen has 0.7, and indomethacin has 1.9. These are the terms where COX-1 and COX-2 is practically almost equal. So whenever the ratio of COX-1 to COX-2 inhibitions is less than 1, you can say it is selectively COX-1. When the ratio is very high, suppose more than 1 but more than 10, 15, you can say that these compounds are more COX-2 inhibitions. So COX-1 inhibitions when the ratio is on the lower side, COX-2 inhibitions when the ratio is on the higher side. And whenever the ratio is on the lower side, right, they will have more GI side effects. This is very, very important. If the patient has acid peptic disease, I would not prefer ibuprofen or naproxen. I would prefer drugs like diclofenac or selective COX-2 inhibitors like celecoxib. Rofecoxib, of course, is not available. So patients having acid peptic disease and we need to give analgesics, though we perceive that naproxen appears to be safe, but that is not safe as far as their COX-1, COX-2 inhibitions are concerned. So ibuprofen, naproxen, indomethacin have more GI side effects than diclofenac and obviously celecoxib. They are selective COX-2 inhibitors. But the other way around, if the patient has cardiovascular problems or a patient, if you have to use for a long term, we should avoid diclofenac and all selective COX-2 inhibitors because they can inhibit prostaglandin productions, which are the inflammatory ones. And against that, the COX-2 inhibitions would not affect the thromboxane. Thromboxane is not affected when you produce only COX-2 inhibitions. And that is why these patients have more chances of thrombosis and severe stroke and cardiovascular diseases. That is why it is better that you avoid NSAIDs in general also for the patients who have got acute pain. Even if the patient has acute myocardial infarction pain, severe pain, we avoid NSAIDs for the same reasons, that it is in chances of increasing the thrombotic milieu is more high with COX-2 inhibitors. Nimesulide is one of the selective COX-2 inhibitors. It's just mentioned to condemn it. Though its analgesic effect is good, but it has already been withdrawn from many markets, and some of the countries like US have not applied for it. The reason is the liver toxicity. The liver toxicity appears in a very few weeks, and it can appear in as short a time as 2 to 3 weeks. So don't prescribe nimesulide as far as possible. Don't prescribe in children under the age of 12 years. Don't prescribe for more than 15 days, and don't prescribe beyond 200 milligrams. So this is what is very, very important in nimesulide. As I said, it's just mentioned to condemn it, that please don't use it, right? If at all other analgesics have failed, You may use it as a second choice, but again, use it for a very short period, like pain, like acute pain or dysmenorrhea, but not again for any chronic conditions. Please do not prescribe. We still find so many nimesulide preparations are available, but we do not know how many of them have gone into liver issues. So before prescribing NSAIDs, we must be aware of many of the situations where we should avoid NSAIDs. If the patient has dehydrations, if the patient is on diuretics, right, then the volume contraction is less, please do not use NSAIDs. Plus, correct the hydrations and avoid a safer drugs rather than NSAIDs. Likewise, if the patient has acid peptic disease, avoid NSAIDs like ibuprofen or naproxen. Patient who has renal or hepatic impairment, they have to extremely cautious in using the NSAIDs. And patient who is receiving ACE inhibitors, ARBs, there also please do not use NSAIDs, because ACE inhibitors and ARBs work on the efferent arterioles, and prostaglandin inhibitors work on the efferent arterioles. Together, they will definitely produce acute kidney injury. So please do not use, or be very careful when a patient is already on ACE inhibitors or ARBs and you have to prescribe NSAIDs. Very, very important. This is not very common. Of course, it's a very rare syndrome called Nikolov syndrome. But because with diclofenac, there are a number of cases reported with intramuscular injections of diclofenac. Patient has immediate pain erythema at the injection site, and there is a biolaceous patch and followed by localized necrosis. That is called a Nikolov syndrome. Nikolov syndrome is present in many drugs, right? It's not only the diclofenac or even it has been reported in paracetamol also. So always keep in mind, or whenever the patient complain of pain at the site of the injections, at least have a look whether there could be something like some local inflammations or necrosis. Now we come to the second big group of drugs called opioid receptors or opioid drugs. Opioid drugs works on the opioid receptors. We have got endogenous receptors which are used for most of the modulations of the pain or the response to pain. These are the endorphins, enkephalins, dynorphins, and nociceptions or orphanin. And exogenous like morphine, heroin, or the fentanyl, they all work on the same receptors, right? The receptors are these. The receptors are mu receptors. The commonest receptor where most of the drugs work are the mu receptors. But there are also other receptors called kappa receptors, delta receptors, nociception receptors, and zeta receptors. We'll be talking mainly about the mu receptor agonist drugs. They are further divided into different types, not of very importance. So the commonest drugs after paracetamol and NSAIDs are the tramadol. Tramadol is used left, right, and center, but please remember that it's an opioid drug. All class of opioid drugs have got a very important habit formations, addictions, and many of the withdrawal symptoms that might occur if you suddenly withdraw these drugs. So this applies to all opioid drugs that we are going to discuss. Please use it for the shortest possible time and never ever withdraw suddenly. Right? Tramadol is one of the most commonly prescribed analgesic from this class of drugs. It's a synthetic mu opioid receptor agonist. It's in the central nervous system it works, but it also inhibits serotonin and norepinephrine. It produces pain relief, especially in the patients who has got moderate to severe pain. It's a very good analgesic drugs, but it's more important in neuropathic pain than nociceptive pains. For nociceptive pain, still paracetamol and probably the NSAIDs are a better choice than the tramadol. It's a potent neuropathic pain, and as I said earlier, neuropathic pains are not easy to be treated. So I would reserve tramadol for those kind of pains. And because of the potential misuse of and the habit formations, addictions, we must always keep in mind that it can produce physical as well as mental dependence, and should be used as less often as possible. The interesting part of tramadol physiology is that tramadol's active metabolite is M1, which is more stronger has stronger affinity for mu receptors, and that is why it is more powerful as an analgesic effect. So M1 metabolite has more analgesic potency. This is helpful when we come to the drug-drug interactions. Tramadol is used for acute pain in a dose of 50 to 100 milligram, 4 to 6 hourly, but do not cross beyond 400 milligram. Of course, in our patients, most of the time we do not go even beyond 150 milligrams. Sure. But chronic non-cancer patients, we usually prefer extended release preparations other than the immediate release preparations. And those we start with 100 milligram. And gradually, every 5 days, we increase to 100 to 150 milligram, 200 milligram. Like that, maximum we should give 300 milligram for chronic intractable cancer pains and non-cancer pains also. Whenever there is a liver involvement or renal involvement, please do not prescribe ER preparations. For hepatic as well as renal impairment, no ER preparations, only IR preparations, that is immediate release preparations, and always those spacing should be 12 hours. So at least keep this in mind for hepatic and renal impairment, IR preparations, and only 12-hourly doses. Tramadol is an opioid drug and should not be used in pregnancy unless all drugs have failed or not responded, and you can prescribe a very low dose of tramadol like 32.5 milligram twice a day. But there are reports of stillbirth, poor fetal growth as well as preterm delivery with the use of tramadol during pregnancy. So as such, it is not used unless it is a compelling indication to use it, and it should not be used during lactation. So very, very important, tramadol don't go beyond 300 to 400 milligram. Always prefer IR preparations, and at least in patients with liver or renal impairment, not more than 12-hourly dosages. Another very important part of the adverse effects of tramadol, this is a class effect. So subsequently, all opioids will have the same effects, and I will be saying that just like the opioid receptors have side effects. Initially, whenever we start with tramadol, we have also experienced in practice, patients would complain of nausea, dizziness, right? Some patients also complain of vomiting, right? So these are very common complaints, and some of them also complain of sedations. And if you see the pupils, they are meiosis, constricted pupils. So these are quite common symptoms, and it usually starts in the initial part. So whenever we prescribe, it is better we start with a small dose, especially when we are prescribing for a chronic pain, right? Start with a very small dose, build up the dose gradually. And once the patient doesn't have dizziness or nausea or sedation, we can increase the dose. But patients who are also receiving another CNS depressants or benzodiazepines or muscle relaxants, always be careful. They can be serious respiratory depressants, and there can also be profound sedation. So tramadol, we must keep in mind that if the patient is receiving in co-prescription other drugs like benzodiazepines or muscle relaxants, many of the centrally acting muscle relaxants like tizanidine or metocarbamol, all that we use, right? Or even baclofen, they are all centrally acting muscle relaxants, and they, along with tramadol, can increase the respiratory depressants as well as sedations. Naloxone is a drug which is it can reverse the effect of tramadol, right? So whenever the patient has a tramadol overdose, or if the patient has sedation or respiratory depressants, immediately we should be using naloxone. Naloxone is a life-threatening, life-preventing drugs for patients with the severe respiratory depressants. And the counterpart of naloxone is naltrexone, that we'll be talking later probably. But remember that naloxone can only reverse the side effects of the respiratory depressants and profound sedations, but it does not affect the serotonergic effect that the tramadol also has, and that is why there might be increased chance of seizures. So whenever we prescribe naloxone, we have to be very careful. Whenever we prescribe tramadol, we must make sure that the patient is not receiving drugs like amiodarone, which is a very common prescriptions for patients who have some cardiac event, or the patients who have got the fibromyalgia, or patient who has got the depression. They might be on drugs like fluoxetine or paroxetine, right? So these are the drugs which have got metabolism through CYP2D6, and these are the CYP2D inhibitors. Inhibitors means they increase the concentration of tramadol, and thereby the increased chance of the serotonin syndrome and seizures. So that's very, very important. They increase the chance, increase the side effects, but they decrease the M1 metabolite. And M1 metabolite is more effective for the therapeutic effect. So they increase the risk and they decrease the therapeutic efficacy. That is why always keep in mind the drugs like amiodarone, fluoxetine, whenever we prescribing tramadol and along with these drugs. Another important drug is linezolid, which again is a very important antibiotics frequently used, though the indications are really few. And linezolid, whenever is used with tramadol, it can produce serotonin syndrome because it's a weak but reversible MAO inhibitors. It can also increase the potential the side effects of anticonvulsant drugs. So, in short, whenever we prescribe tramadol, always look for the co-prescription of the other drugs. Tapentadol is not very routinely prescribed drugs, but is again a very powerful drug which is working on the moderate to severe pain. It should be kept as a reserve drug for very refractory pain, right? Or when we need a very powerful analgesic in certain situations. It's an opioid drug. Dose is usually 50 to 100 milligram. And again, just like the tramadol, better avoid with the MAO inhibitors like the linezolid, and side effects remain same. And there is a specific warning in the manufacturer's leaflet that please do not use beyond 5 days. So tapentadol, whenever we use, it should be used only for 5 days and not more than 5 days because of the serious side effects, mainly over the GI tract as well as the long-term side effects. Buprenorphine, it's not routinely used analgesics. It is used for patients who get chronic intractable cancer pains or patients who are already on opium for a long time. Patients who have got opium use disorders, OUD, right? There, buprenorphine will help in the withdrawal symptoms preventions, right? So buprenorphine is, though opioid drug, it is partially agonist, and that is why it helps in the withdrawal, or we can take out the patients from the opium addictions by way of supplementing with buprenorphine, which will work as partial agonist and which will also relieve the pain. It has got a very prolonged action, so all that we have to do is just give 1.2 milligrams sublingual tablet, or the transdermal patches are available, 5 milligram and 20 milligrams. Injectables we generally don't use, but it's a very powerful analgesia that it produces. Important thing, the most important part of buprenorphine is that it has got something called a ceiling effect. That means if we keep on increasing the dose, the side effects are not increased. It just does not work because the initial dose only saturates the receptor. So by increasing the dose, we do not get the high that the patient gets with the morphine or pethidine. That patient get euphoria. That feeling will not come with buprenorphine. That is why it is very helpful in withdrawal of the opium. Only important part is whenever the patient has opium withdrawal, only after the withdrawal symptoms start, we should be using the drugs. Otherwise, there can be some symptoms, side effects of these drugs also. And the buprenorphine side effects are same as for the opioid class, that is sedations, nausea, vomiting, constipations, meiosis. Fentanyl is a very, very good drug, very powerful drug. It's also a synthetic opioid, and its efficacy is 30 to 50 times more than the heroin and 100 times more than the morphine. Many times, the most of these people who use these substance abuses, their fentanyl is contaminated deliberately to get the highs. So it also activates mu types of opioid receptors. It's a very powerful analgesics, and not only a severe cancer pains, but many of the post-operative pains where we have to use it for a short period. It's a wonderful drug. When we have used it in patients who have got severe pain like acute pancreatitis, it's a wonderful results. All that we have to do is just give an infusion of fentanyl 0.5 to 1.5 milligram per kilogram per hour, and excellent results with such conditions where we do not have many drugs. We can't use NSAIDs, we can't use paracetamol in conditions like that. So we can use this kind of drugs for serious conditions like pancreatitis also, these drugs. Usually it's available as 50 microgram per ml, and very important post-operative painful conditions and conditions like pancreatitis, we can use it. Even patients where we have to produce some procedures or post some, say, some fracture reductions, we have to do it in, or patients we have to do Bun's dressings, right? That is where these are very painful conditions. We can use either fentanyl or ketamine that we are going to discuss next. These are the drugs we use for a short period. Excellent analgesia. This being an opioid preparations, we have to make sure that patient doesn't get access to that later on. Ketorolac is non-opioid powerful analgesics. Many people use ketorolac, particularly the surgeons have a preference for these kind of drugs, right? We use more of NSAIDs like the ibuprofen or diclofenac or naproxen. But ketorolac is also very powerful drugs. Like tapentadol, even though it is non-opioid, we should not use for more than 5 days. And it's for short period, moderate to severe pain, and it should not be used for mild to chronic long-term pains. Ketorolac only for short-term analgesic use, that we at least keep in mind. And usually the dose is 30 milligram intramuscular or 15 milligram IV. And when we give orally, the first dose should be 20 milligram, and then we give 10 milligram every 4 to 6 hourly, not more than 40 milligram. Ketorolac should not be used when the patient has got an advanced chronic kidney disease. When the creatinine clearance is less than 30 ml per minute, do not use ketorolac. For that matter, most of the NSAIDs should not be used whenever the patient has got moderate to severe renal impairment. Ketamine, as I said, again, a very, very important drug, very good analgesia, and in a higher dose, it's also has got an anesthetic property. It's again non-opioid analgesics, and it is an NMDA antagonist. NMDA is the one which is required for the modulations of these sensations. So when the patient is on ketamine, he just goes into a trance-like state, or what we call as a dissociative anesthesia. So here the patient can undergo many of the procedures, as I said, like the fracture reductions or dislocation reductions, or say burns dressings or laceration dressings, wound dressings, which are very painful conditions. We can use either fentanyl or ketamine. Ketamine, we can use it in a higher dose for general anesthesia. For a smaller dose like 0.1 to 0.2 milligram per kg, it will give a very good analgesia. But as it is mentioned in the textbook, that do not give beyond 0.15 milligram, because it doesn't add to the efficacy, but the chances of respiratory depression remain. So better use in a smaller dose for a good analgesia. Again, because of its NMDA antagonisms, it might produce hallucinations, weak dreams. That is something we keep in mind when the patient is coming out of the anesthesia or coming out of the effect of ketamine. By and large, a very good drug, very safe drug. Now, the last part of the talk, that is about the neuropathic pains, or when we use gabapentinoids. We use these gabapentins and the pregabalin these days in such a large number that we need to know whether if they really need to be used in that numbers. And the drugs like amitriptyline has got a very good NNT if we see compared to the gabapentin or the paroxetine. So it's very important that the NNT for post-herpetic neuralgia for amitriptyline is 2.3, and for diabetic neuropathy is 3. So if the patient is young, and he has got the herpetic neuralgia, diabetic neuropathy, I will be using first amitriptyline, because the effect starts almost in a very short time. As against the gabapentin or pregabalin, it takes time for its actions. But of course, amitriptyline has got many anticholinergic side effects. So is gabapentin, it has got a side effect. So gabapentin, the post-herpetic neuralgia, the NNT is 3.7, and for diabetic neuropathy is 3.2, still better. For trigeminal neuralgia, as we say, most of the people would obviously be starting with carbamazepine as the first drug, and or the lamotrigine nowadays. So these are the drugs which has got a very low NNT. For painful diabetic neuropathy, people have been using paroxetine and duloxetine, but they do not have the same efficacy as the amitriptyline or gabapentin or pregabalin. So gabapentinoids, they are the drugs which have an effect on the GABA aminobutyric acids, but not the direct inhibitions. They work on the voltage-gated calcium channels, which affects the GABA transmissions, and that is how they work. They are very good drugs for neuropathic pain. Please do not use for nociceptive pain, which we have got a better and safer and effective drugs which works immediately. Use for neuropathic pain. It's also they are the drugs which are anticonvulsant, especially gabapentin and pregabalin. They can produce CNS depressions. They we have to keep in mind that these drugs, all gabapentinoids, they are excreted exclusively by the renal route. So whenever the patient has got uh, EGFR on the lower than 60 or less than 40, always be careful in using the dose, and the dose has to be halved. If it is, we'll come to that in the next slide. So always keep in mind that this is important because many of our diabetic patients, when they have neuropathy, they also got nephropathy. We have to keep in mind the dose of these drugs whenever we prescribe these drugs to the patients. So they are FDA approved indications of these gabapentinoids are post-herpetic neuralgia, diabetic neuropathy, fibromyalgia, and restless leg syndrome. These are the only FDA approved indications for using gabapentin and pregabalin. There is nothing much to choose. We here use more pregabalin, but elsewhere gabapentin is used. But they are both almost practically same drugs with very few differences in their uh, outcome. Off-label uses, many patients are being prescribed for chronic back pain, for migraine prophylaxis, insomnia sleep disorders, or alcohol use disorders, but they are not the approved or validated indications for the use of gabapentin and pregabalin. The dose of gabapentin is usually, to begin with, is 100 to 300 milligram, and we can go up to 900 milligram. Pregabalin is 50 to 100 milligram. We can go up to 300 milligram. But when the patient has chronic kidney disease, especially when the creatinine clearance between 30 and 60, use 50% dose, right? And for patients who have got between 15 and 30 ml per minute creatinine clearance, give one-fourth of the dose and use very small dose when the patient has got an end-stage renal disease. So very important, gabapentin, whenever we use, check the creatinine clearance, check EGFR, and adjust the dose accordingly. These are the drugs which has got a class effect of drowsiness, dizziness, weight gain, peripheral edema, and they should not be withdrawn suddenly because they can produce a lot of complications if they withdraw suddenly. Something that we have to keep in mind when we have to change the drugs. We change from these drugs to any other drug. Make sure that we do not withdraw it abruptly. Last very important part is topical analgesics are the drugs which at least are very, very useful in the acute pain, nociceptive pains, like whether the sprain or muscle spasm or something. And this is an underused modality of analgesics. So I would say whenever the patient has a local pain, nociceptive pain, first try topical analgesics. Topical analgesics have got many ingredients like NSAIDs, like diclofenac is there in many of them, menthol, salicylate, capsaicin, local anesthetics. These are all different kinds of ingredients, and many of them have combinations of menthol and NSAIDs or menthol and salicylates are available. They are available in creams, gels, patches, spray. All they are available, and they are excellent analgesia. As you will see, that topical NSAIDs provide 50% of the pain relief compared to the placebo, which is a very, very good achievement. And for diclofenac gel, the NNT is just 2. If you treat 2 patients, at least one patient will get the benefit for this kind of pain. So it's an excellent use of analgesics and with a safer. Most of the people do not use it because of the fear of systemic absorption. Systemic absorption is very meager, 1 to 7% only across all NSAIDs, right? So please do not worry about the systemic absorptions and use topical analgesics as the first drug for most of the musculoskeletal pains or acute pains. And that is what I would suggest is something that I would strongly advocate. Please use topical analgesics as and when indicated or as the first line of drug. Topical, this is just the importance of the different formulations which are available for the topical analgesia. It's available as ointment, cream, lotion, gel, and whenever there is an ointment has, it all depends on how much is the oil content and how much is the water content. If the ointment has more oil and less water, gel has 100% water. So ointment is greasy, obviously, because it's an oil, petroleum in it, and it is thick and greasy. It's for prolonged slow absorptions. Whenever you have got the dry skin, patients at the dry skin or cracked joints or psoriasis, always prefer ointment. While when you want rapid actions, or then obviously you need something like gel. Lotion is for something where we use it over a large area, right? Because it is absolutely watery and it is very lightweight. So use lotion when you have a large area, hairy skin, or mild pain relief. But for strong pain, joint pain, dry skin, better use ointment. And gel is for very acute relief of pain, so is the spray. So to conclude, correct diagnosis of type of pain is very, very important, right? Nociceptive pain and neuropathic pains are the two important. Then management of pain is different in both types of the pain, as we have said. There is no one size fits all formula for pain management. Keep in mind number needed to treat. Analgesic dose is different than the anti-inflammatory dose, and as we have said, the ibuprofen, the analgesic dose is much lower, half than the inflammatory dose. Combination of analgesics and NSAIDs give very good results with a lesser dose and safety profile. Local application of analgesic is underutilized for at least musculoskeletal pain for fear of systemic absorption. And whenever we prescribe analgesics in presence of hepatic or renal impairment, be very, very careful. Be careful when patient is dehydrated, patient ACE inhibitor, patient is on diuretics, and drug-drug interactions, especially the drugs like cardiac drugs like amiodarone or antidepressant drugs like fluoxetine or paroxetine, or drugs like linezolid, and prescribe analgesics for minimum dose and minimum durations. Thank you.
Thank
I look for pregabalin, Dr. Anand, but I could not get it. But I presume that it is almost same as the gabapentin.
s- there's one more question, sir. I'll just
Yeah,
the
sure.
longer one here. Dr. Ashish has asked, drug re- ribampi- ribampide,
Me fine.
Ribagen is the common
Mm.
trade name, is known
Mm.
to reduce the prostaglandin inhibition in stomach and the bowel. Can it be co-administered with NSAIDs to partly counter effects on the stomach and intestine? Prolonged
I'm
PPI and NSAIDs are said to be nephrotoxic combination.
I can answer the second part, the PPIs and nephrotoxic, agreed, but I am not aware of the rebapimipide. I am not sure about Ribagan. Probably what we have seen, people use it in the hosta of aphthous stomatitis, that they are using it, but I am not sure whether it is falling in this group. I'm not sure, honestly. But PPI definitely, proton pump inhibitors for more than one reasons are nephrotoxic, and there are enough reports to say that it produces acute interstitial nephritis also on a long-term use. And these days, the PPI has to be used on a very limited indications like known acid peptic disease or H. pylori, or when there is an gastroesophageal reflux disease, right? Or a gastritis because of the drugs. So, and PPI should otherwise also not be used for more than 6 to 8 weeks, and then we should review.
So we have a question by Dr. Poonam. Which analgesic and anti-inflammatory drugs are safely given in a patient of cirrhosis of liver?
As I said, it's a very difficult situation, but cirrhosis of liver patients, definitely we have to be very, very careful in using the drugs like paracetamol, but we can give up to the dose of 2 grams per day. If that doesn't take care of the patient's pain, then probably we have to give a small dose of tramadol only, because NSAIDs would be more toxic, right? So I would prefer after paracetamol in a small dose. If doesn't work, then tramadol.
Yes, thank you. So this question is not directly related to the topic, but Dr. Jaishree has asked, can you highlight on the pain score?
I do not know what does it mean. If cyanosis, I'll definitely, we would all like to know. Usually, what we see is a visual analog score, but whenever we study any drug, right, we call VAS score. VAS score is visual analog score. That means patient is shown a strip of 1 to 10 and say that what is your pain today. If patient says 7, then you give a drug, and next day you ask what is the score, whether the VAS score is decreased or not. If there is a score another than, I am not sure about it. What is the pain scores he's talking about? there are different scores for different situations, like acute pancreatitis, there are different scores. But selectively for pain, I am not aware.
Yes, sir. So Dr. Ravindra Kulkarni has asked, how are narcotics and hypnotics different from the analgesics?
See, basically, narcotics is a generic term of the opioids, right? And they have got there's more powerful drugs are narcotics, but opioids and narcotics are the same, and they are the powerful analgesics. They are no different than the analgesia. But analgesia is what we use for medical persons. Basically, people use it for a different purposes, for heighten their stimulations, CNS stimulations, and all, for getting that effect of high euphoria effect. So that is what it is. Otherwise, same. Narcotics and opioids are the same. Right?
Dr. Suresh has asked him, is it safe to combine tramadol with other NSAIDs?
We can combine. There is no only thing we have to keep in mind whether the patient has any of the contraindications for not using it. Usually, the tramadol is combined more often with paracetamol than the NSAIDs. Right? That is because they have been found to be having a good synergistic effect. I am not aware whether there are any combination preparations available with tramadol and any of the other NSAIDs. But theoretically, we can definitely use it in a smaller dose for the drugs if required. Sure, because the side effects of NSAIDs and tramadol are different. Tramadols are more CNS side effect, right? NSAIDs are more hepatotoxic and renal side effects. So
Yes, sir. So Dr. Ashwini Patil has asked, so trombiflem, that is tablet paracetamol and tablet diclofenac. No, it is ibuprofen.
it is
Where we,
ibuprofen. I
yes,
didn't name drug when I said that the good drugs are most commonly prescribed analgesic and analgesic anti-inflammatory is combiflam. Yeah.
yes, sir. Where do we use them, sir? And can you please explain is that question?
See, if the patient has an acute injury, sprain, severe pain, or let's say patient has come with chikungunya, suppose, right? Obviously, simple analgesics like tramadol is not going to, or paracetamol is not going to work. We need to give analgesic drugs. So I would prefer a drug like this or standalone only anti-inflammatory drugs. So these are the situations where probably we'll be combining both because that will reduce the pain as well as inflammations. So whenever we want to give the analgesic, powerful analgesics, and we don't want to give higher dose, maybe we'll combine the ibuprofen and paracetamol combinations. We can use it in so many situations. Many times in the febrile situations, like say flu conditions, right? When there are no other contraindications for not using the ibuprofen. If we give paracetamol, we might have to go every 4 hourly. But if we combine ibuprofen and paracetamol, probably we have to give it only 2 or 3 times a day. So, known acute conditions with a patient otherwise healthy, I would prefer paracetamol and anti-inflammatory combination and such combinations.
Sir, thank you. Sir, Dr. Madhav Kulkarni has asked, do antioxidants reduce the ADR possibility, adverse drug reactions?
That has always been going on for long, but only if the patient has deficiency, it would help. Is otherwise, antioxidants truly do not help in any situations.
Dr. Rajendra is asking, is there any difference of action between diclofenac sodium and diclofenac potassium?
Diclofenac potassium is a very short acting, means a very fast absorption drug. So that is why the diclofenac potassium is short acting, and diclofenac sodium is long acting. When we use it for a very short period, right? So acute pain we want to relate, I would prefer diclofenac potassium. But when we use for a joint pain where we need a long duration of action, I would prefer diclofenac sodium. So potassium and diclofenac potassium did come, but did not last long because most of the times when we use diclofenac, we use it for a prolonged actions of a prolonged analgesic action. But potassium is mainly short acting and fast acting. Acute onset, short lasting pain.
Yes, sir. Uh, Dr. Sandeep Jagtap has asked, what would be the choice of drug in CRF with hairline fracture of the lumbar vertebrae? Chronic renal failure with a fracture of lumbar vertebrae, epidural anesthesia, or any other?
Uh, I think the best thing first is obviously to immobilize the lumbar vertebra with help of the belt, right? And then we can use it for a very short period when there is an acute pain. I will use a drug for a short period like ketamine, right? For a short period, right? Then we can definitely use paracetamol, right? In these situations that because it's only circadian, not uh, hepatic involvement, and a small dose of any of the drugs can definitely use, but tramadol probably would be a preferred drug, right? Anesthesia, I would leave it to the surgeon whether they really need to give it, but I am not sure epidural anesthesia would work for the lumbar vertebra. We have to give this at a higher rate, and that is always a danger of damaging to the spinal cord. But sacrum lower down, it's different.
Yes, sir. Dr. Roshit has asked any superiority for etrosicloprid among NSAIDs in efficacy and stomach protection, and any specific side effect to take care.
See, basically, etorecoxib is like the all coxips, like that is selective COX-2 inhibitors. So
Yeah.
practically, amongst selective COX-2 inhibitors, the best drug that has been so far recorded is celecoxib. 200 milligram is the dose, right? Etorecoxib and many other drugs, they are being marketed, but they are all COX-2 inhibitors and they have got lesser GI side effects. But as I said, because the COX-2 inhibitors also reduce the prostacyclins, which are very important preventive as a preventive role. COX-2 inhibitors for a long term, please do not use it because they increase the chance of thrombosis, increase the chance of cardiac events as well as stroke. So etorecoxib, efficacy wise, is probably same as celecoxib. So if you use it for a short period, definitely, and patient has acid peptic disease, I would definitely use one of the coxibs for acid peptic disease because they are GI safe, GI friendly. I would definitely use it, but not for a long term when the chances of the damage to the cardiovascular and severe CNS side effects of preventing stroke remains poor.
Yes. We'll take a last few questions, sir, in
Sure, yeah.
interest of time. Yes, sir. Dr. Jayashree Sampath has asked, transdermal patches, do they have systemic absorption?
Yes, it has a systemic absorption. That is how it works. It's not doesn't work for the local, but it's always the mechanism is such it releases a very small quantity, graded quantity. If you apply a patch of this transdermal drugs like uh, fentanyl patch, then it will work for 7 days. So it's a patch which is working for 7 days and not for 1 or 2 days. Many of the patches, buprenorphine patches are available. That is to be like once in 7 days. So if you light the 10 milligram of patch, it will work for 7 days. So it is there is the system action because the mechanism of action is over the central nervous system. So it's going to work by systemic absorption, but the preparation is such that it produces a very gradual absorption. So the effect would be gradual and long lasting.
Sir. Dr. Praveen Kumar has asked in how to predict sensitivity to diclofenac as the skin prick test carries no meaning and is only of medical legal purpose.
I do not think that we need to do the diclofenac skin prick test at all. I do not. I am not sure whether it has been mentioned there in the literature or somewhere. We don't do, or it's not required for any NSAIDs for that matter.
Uh, what is Dr. Madhav Kulkarni has asked your opinion on piroxin?
Piroxicam, indomethacin, meloxicam. Piroxicam and meloxicam are definitely more towards the ibuprofen and diclofenac if you've seen the chart of the COX-1, COX-2 inhibitors. So they have got good analgesic effect definitely, but they have got also more GI side effects. They are more COX-1 than COX-2. So they have got more side effects. And that is why they are not, but selectively some conditions like say, acute gout, piroxicam is preferred to the doctor. So there are certain situations where probably piroxicam has found to be better, right, as an analgesic for. So particularly, as I said, acute gout, we have found that piroxicam is one of the best drugs as an analgesic drugs after the obviously the colchicine.
Yes. We'll take one last question, sir. Whether pregabalin or gabapentin is better in heart failure patients.
I'll be conscious for both. either of them for two reasons, because they produce weight gain, right, and their effects are never immediate. And in heart failure, there are other options available for these drugs. They are the drugs to be used very carefully, especially if the patient has heart failure. Have to be very carefully using these drugs.
Thank you so much, sir. That brings us to the end of the Q&A section and also the session. Thank you
Thank
so
you,
much
everyone.
for
It was pleasure, and we enjoyed in the discussion also. And we wish that this whatever we have gained, right, is percolated to the patients at large, and in our prescription also it makes a difference, because you have to be very very careful. And analgesic prescription, as I always say, is always very active participant prescription writing. We do not prescribe just because somebody else said this is a better drug than the other drug. I would prefer the analgesic drugs to be given only after careful consideration of patients, whether it's an acute or chronic, nature of pain, as well as whether he has got underlying hepatic or renal involvement, and how long we are going to use it, and by any chance there is a heavy potential of that particular drug. Thank you. Good
thank you
night.
so much. Good night, sir.